Hello, everyone. Welcome. My name is Katie Brown, and I'm the U.S. Marketing Activation Manager for SD Health and Medical. Thank you for joining our session today. Today's webinar topic is the skin's hidden enemy in healthcare, MARSI. MARSI stands for Medical Adhesive Related Skin Injuries. And we're very lucky to have Kimberly LeBlanc with us today as our presenter. Kimberly LeBlanc is known globally as an innovative nurse leader. She is the current academic chair of the Association for Nurses Specialized in Wound Ostomy and Continence Canada's an advanced practice and certified wound ostomy and continence nurse working with KDS Professional Consulting, and is the president-elect from 2022 to 24, president 2024 to 26 of the Canadian Nurses Association. She holds a doctorate of philosophy in nursing from Queen's University. Kimberly is an affiliate lecturer at McGill University and an honorary senior lecturer at Cardiff University. Kimberly is a past president and founding member of the International Skin Tear Advisory Panel and the past co-chair of the Canadian Pressure Injury Advisory Panel. She is currently a board member of the International Wound Infection Institute and the Commonwealth Wound Care Resource Alliance. In 2020, she was inducted as a fellow of the Canadian Academy of Nursing, and in 2022, she was awarded the World Union of Wound Healing Society's Gold Award for outstanding global contributions to innovation and skin integrity. Kimberly has lectured extensively on wound and ostomy care and is considered a global expert on wounds and ostomy issues in the aging population, and has numerous publications and book chapters on wound, ostomy, and continence-related topics. And then, so just before we get started, I will go over just some general housekeeping. To minimize disturbances, everyone has been placed on mute. If you have a question during the presentation, we encourage you to ask them via the Zoom platform. So please feel free to ask questions at any point during the presentation using the Q&A box at the bottom of your screen. Questions are not visible to other participants, so it will not be an interruption for your fellow viewers. We have reserved time at the end of the presentation to answer as many questions as possible. As a reminder, this session is being recorded. We will send out a copy of the recording to all participants tomorrow. With that being said, I'll hand it over to Kimberly LeBlanc to get started.
Thank you. Welcome, everyone. Thank you for joining us today. And thank you to SD for inviting me to speak to you about a topic that's very near and dear to my heart. Oh, let me see if I can get this to move forward. So just some disclosures that I have given some talks for industry, as well as received some research support. What we're going to be looking at this today is at the end of this session, I wanted you to be able to discuss the different types of mechanical injuries that are associated with MARSI, to describe the important role education plays to advance practice in MARSI care, and to discuss the importance of prevention and risk reduction strategies. So let's take a step back and let's talk about medical adhesive related skin injury. We know that it's greatly overlooked and underestimated. People just expect that it's a normal part of when you go into hospital or when you have adhesive use. So despite the frequent use of medical adhesives in all healthcare settings, we have very little awareness of what MARSI type injuries are, and that they're rarely reported. So we don't know the true incidence and prevalence of this type of injury. But it's expected to rise as the population ages and more premature babies survive. And you can see in this picture here the number of skin tears that this individual has, and these were all related to intravenous and the tapes used to secure it. Medical adhesive skin injury is a term used to define any skin damage related to the use of a medical adhesive product or devices, and this includes tapes, wound dressings, stoma products, electrodes, medication patches, and wound closure strips. And we know that this type of injury is largely avoidable, and that's something I think is really important for us to consider because we do no harm. So it's super important that we really think about the fact that this is preventable. What does it look like? It comes in many different shapes and sizes and across the continuum of care. It can occur when the attachment between the skin and the adhesive is stronger than that between the individual cells, causing either epidermal layers to separate or the epidermis to detach completely from the dermis. And this is when we have mechanical trauma. A medical MARSI represents skin damage as the result of exposure to medical adhesive products or devices. We know that it is occurrence of an alteration in the skin integrity. So there can be erythema or other skin alterations. So we can get skin tears, erosions, bulli, vesicles. And normally what we would see is it's persistent for more than 30 minutes after removal of the adhesive. So as I said before, we don't know what the true prevalence of MARSI is. It's so underreported. There's been some data that's looked at the different types of MARSI, that overall it could be as high as almost 20%, with the highest being contact dermatitis, mechanical skin injury. So in one study by Ferris in 2015, they saw a daily prevalence of MARSI to range from 3.4 to 25%. So this is huge, and this is something we need to really look at. If 1 in 4 of your patients develops an issue related to an adhesive, we need to look at how we're using our adhesives. So I'm not going to read through all these studies with you, but this is just to show that there's really not very much out there, and there's a wide range of prevalence reported depending on the care setting. We do see slightly lower prevalence in the long-term care settings, and part of that is because we don't use as much adhesives in our long-term care settings. But in the acute care setting, this is where we're seeing 25%. So the other thing to notice here is that not a lot of studies done. So we did a lit search to see how many studies I could find. Really not very many out there showing that were actually showing the prevalence. So we need more studies done. And particularly Dr. Usi and her team in 2016, they wanted to look at individuals' knowledge, attitude, and practice. And what I thought was super interesting was that 71% stated that the occurrence of medical adhesive-related skin injuries weren't reported in their facility. And only 31% even knew what medical adhesive-related skin injury was. So that tells us we have a lot of work to do to raise awareness. So if we look at the impact of medical adhesives, 64% of clinicians said injuries caused by medical tape are serious issues. 55% reported that they had patients develop skin issues as a result of improper application or removal of medical tape. So this was a study done back in 2008 by Cutting. So what is this telling us? We started talking about this in the early 2000s, and here we are, 2023, and we really haven't seen any significant change. So we need training on how to properly use medical adhesives, but we know it doesn't get a lot of attention. I didn't learn about it during nursing school. I know my daughter, who just finished nursing at university, didn't get much. 3 in 4 clinicians said that medical adhesive play a critical role in providing high quality care, and 69% of clinicians use medical adhesives multiple times a day. And only 38% received training on adhesive use. And this is, once again, was from Cutting's study back in 2008. So we haven't made any real changes or inroads. So I guess my challenge to those of you on the call today is be a change agent. Go back to your areas of practice and see how you can change practice in your area of work. So managing, preventing MARSI, it's really the whole gamut. We need to look at it the same way as we would looking at preventing skin tears, pressure injuries. We need to do an assessment, prevention, treatment, product selection, and application and removal review. When we're looking at predicting MARSI, there's no predicting scales that have been validated. There's none that have even been developed to my knowledge. There have been some consensus groups that have been done. So for Lamero et al. Back in 2020, did come up with some of the risk factors that they felt would contribute. And this includes longer hospital stays, longer treatment times in the community, increased professional time, decreased dressing usage, increased morbidity, delayed wound healing, scarring, increased risk of complications, including infection. So these are some of the things that they said MARSI can contribute to. So Zhao et al. In 2018, they did a multivariate analysis, and they discovered that there was a few risk factors for MARSI. One was being greater than 50 years of age, having a hematologic malignancies, and history of skin allergies. Li et al. Just this year looked at a bivariate analysis, and they identified 5 factors, which included using a TPN, history of MARSI, other catheter-related injury, history of allergy, and PICC implementation. Now, what I found interesting was the history of MARSI, because we know from studies we've done that one of the greatest predictors of developing a skin tear is having a history of a previous skin tear. So one has to wonder, how much overlap is there with MARSI? We know that skin tears are a type of MARSI, and MARSI are a cause of skin tears. So we do know that there is a lot of overlap. So I think we need to start looking at a bundled approach to care. So if we look at some of the risk factors, we have intrinsic and extrinsic. So intrinsic, the things we can't change or are difficult for us to change, include things as extremes of age, dehydration, malnutrition, dermatological conditions, comorbidities such as diabetes, infection, chronic venous insufficiency, and edema. And if we look at our extrinsic factors, we have dry skin, we have prolonged exposure to moisture, certain medications such as corticosteroids or chemotherapeutic agents, anti-inflammatory agents, radiation therapy. We know that photo damage, so sun exposure over time, can thin the skin and flattens those epidermal junctions and makes it more likely that someone could be prone to skin injury. And we know that tape, device removal, repeat taping, and itching can all be extrinsic factors that can relate. And if we think of the ostomy community, we see a lot of MARSI in that community, and it's because of they have no choice. It's prolonged use of adhesives, and it's constant removal of the adhesives. So if we look at some examples of some medical adhesive devices with adhesives, so all the fixation devices for diagnostics, so those electrodes, I've seen some horrible skin-related issues, so MARSI issues related to the patches that we'll put on when we're, doing heart monitoring. Skin closure strips are known to cause a lot of MARSI. And this is one of the reasons why the International Skin Tear Advisory Panel has advised that we shouldn't use skin closure strips when we're managing individuals with a skin tear. We know the stoma products, wound drainage bags, any advanced wound care dressing with an adhesive, tapes, all the different tapes that are available, urethral catheter fixations, urinary sheath securement. So we have a lot of different products that we know can really contribute. We know that there's types of adhesives used in medical products come in a wide range as well, from silicone to acrylic to hydrocolloids. So if we're looking at skin injury, there's a couple take-home messages. Medical adhesives related skin injury, they're adverse skin reactions. They're harms that result from the use of medical adhesives. Medical adhesives related skin injury can occur in anyone requiring a medical adhesive. And I think that's super important to remember. And they're avoidable when preventative measures are implemented. And if any of you have ever had a dressing put in place, you know that sometimes it's that anticipatory pain of just the dressing removal can be very painful and traumatic for individuals needing dressing changes, particularly among our pediatric population. And we know that if we start having peri-wound and other injury and other injury related to adhesives, patient safety is now an issue, quality of life is an issue, and we know that healthcare costs are going to greatly increase. So how do adhesives work? So adhesives are designed to be pressure sensitive. So as firm pressure activates the adhesive. So we put an adhesive on. Over time, that adhesive, it's a liquid. It will actually flow to fill in all the gaps and crevices of the skin surfaces, increasing the strength of the bond between the adhesive and the skin. And so it'll continue to increase its bond for several days. And then there will be a slow gap as the adhesive level lowers. So soft adhesives like silicone have low surface tension and fill in the gaps quickly. They maintain the same level of adherence over time. Versus adhesives such as acrylates adhere and flow into the gaps more slowly, and their adherence actually increases over time. So this is something to keep in mind when you're picking your adhesive. So this is just showing how you can see in the top photo, initially there's gaps, and then over time it actually fills in and becomes much stronger, whereas the silicone fills the gaps immediately and they stay stable, which is one of the reasons why in the fragile skin community, when we're looking at skin tears prevention, we will often, the ISTAP will recommend that we use silicone-based products. So there's this great article that has come out looking at medical adhesive related skin injury by Fermarello et al. And I really strongly suggest that you go and take a look at this. It's free for download through the Journal of Wound Care. It's an international consensus document. And here they do a great job of really laying out MARSI in a way that you can take these key pearls and immediately translate it into your practice. So some of the key take-home messages is we need to be assessing all the different areas where it can occur. We know that everyone's at risk. We know that the skin should be assessed each time we use a medical adhesive and every time it's removed. We need to look for any kind of skin changes, and we need to follow evidence-based clinical guidance. So we know that from my skin tear research that MARSI has been reported to be the third leading cause of skin tears. So we see this frequently where, especially in the acute care population, that it's a huge problem. And some individuals are so terrified of going to the hospital. And one of the reasons is all the tapes that are being used on their skin. Now, there's different types of medical adhesive related skin injury. We have mechanical, and that includes epidermal skin stripping. So this is just removal of one or more layers of the stratum cornea. That's when you get that shiny kind of, doesn't really look like a wound, but it's that shiny skin. The other thing that we can see is tension blisters. I don't know if it's showing up too well in your photo, but there's a lovely little blister right here. And tension injuries or blisters occur with separation of the epidermis and dermis. It's caused by shear forces as a result of tension of the skin under this adhesive product. So often what we'll see happen is that people will put adhesives on and they'll stretch it to put it on to try and they think get a better seal. And then as it pulls back, it causes a shearing injury. I see this a lot in my ostomy clinic. So I will see a lot of patients who will come in with tension because they think if they pull the tape on really tight, it's going to hold their appliance on better. So then we end up getting a lot of tension blisters. We certainly also see a lot of tension blisters in the orthopedic population when there's casting involved. And as I talked about before, we have skin tears, which are traumatic wounds caused by mechanical forces, including the removal of adhesives. Then there's also dermatitis. So you can get two different types of dermatitis with MARSI. You can get irritant contact dermatitis. So this is irritation or inflammation that's caused by the irritant of the chemical and the adhesive on the skin. This is not to be confused with allergic dermatitis. So when you have irritant contact dermatitis, it'll be more diffuse. It won't necessarily follow the exact shape of the product. Whereas allergic contact dermatitis is when you actually have an immune-mediated inflammatory response. So it looks similar to irritant contact dermatitis. And you can see in this picture here, someone with a stoma, and you can see the complete ring of where the adhesive was touching the skin versus the inner, we used a soft barrier ring, and the barrier ring, you can see that there right around the stoma, the skin looks wonderful. And then just around it where the adhesive actually touched the skin, we have this look in the exact shape. One interesting thing when you have allergic contact dermatitis is that you may sometimes see, if I were to put the same adhesive somewhere else on the body, the individual may have a reaction to their peristomal skin, even if we don't have that adhesive touching their skin there. So it's just something to keep in mind, that there is a difference between irritant and contact dermatitis. When in doubt, this is when we consult our dermatology colleagues or our nurse practitioner, dermatologist, or a wound care specialist to assist with the proper diagnosis of, is this irritant or contact dermatitis? Treatment is often the same. That's the good news, that we will often use steroid ointments. We try to avoid any cream ointments. We try to go with ointments, rather than creams, because of the preservatives that are in creams. They will often add to the irritation. Other forms of MARSI can be maceration, and this is where we have moisture caught underneath the adhesive, or folliculitis, and this is when we can have inflammation of the hair follicles that can be associated with routine removing of the hair with the adhesive. So just showing some of what I've just talked about, where we have the epidermal skin stripping, the tension blister, and I think this photo here of the tension blister is really quite clear, where you can see this. They have a wound and they'd had it taped circumferentially, and they developed this tension blister from the adhesive. Another example of the tension blisters, you can see it here on the sides where there was tension. Then we have the mechanical skin tears, as I talked about. So commonly used medical adhesives, we already talked about this, the different types of products out there, but we have to just be cognizant of anything that we're going to stick to someone's skin, it's an adhesive. And I already talked about the fact that wound closure strips, not recommended for skin tears by the International Skin Tear Advisory Panel. So what are we going to do? Well, first and foremost, we're going to avoid the use of adhesive products on fragile skin. We're going to use the lowest level of adhesives possible. So quite often we will go to the silicone dressings for individuals that have very fragile skin. And sometimes if their skin is super fragile, we try to use no adhesives whatsoever. But cognizant that in acute care, that's not always possible. So we want to be purposeful when we select our adhesive. Select tapes based on clinical need, clip or trim hair, clean and dry prior to application of your adhesive product. Remove tape or adhesive slowly, keeping it horizontal and close to the skin. So you're pressing and you're pulling far and away, but you're doing it horizontal and very close to the skin. We want to remove in the direction of the hair growth. Skin barrier films, we may want to use those when appropriate, but please, 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 if you're going to use a skin barrier wipe or the lollipop, let it dry completely before you put your adhesive on, or you're going to end up with a moisture associated injury. So some of the strategies is, so if you have improper tape selection, so you're not doing the proper tape selection. So what is our action? We want to make sure that we're selecting our tape based on clinical need. So we need to have different ranges of tapes, from paper tape to silicone tape to the acrylic tapes, based on need. And we have to remember that when we're looking at the extremes of age, we should always go to the lowest possible adhesive. We can see that we need to prepare the skin properly. So sometimes the hair isn't removed, the skin is soiled, wet or moist, or residue left on the skin. The preps aren't allowed to dry. Adhesives promoters are used. We should never use adhesive promoters when in combination with aggressive adhesives. We never want, or used in combination with a heating device. So sometimes we'll see people taking hair dryers to heat adhesive to try and get it to stick better. What you're doing is increasing your risk for MARSI. So what you want to do to mediate that is climb or trip the hair, clean and dry the skin well, only use skin barrier films when appropriate. Know your dressings. Some dressings are not compatible with the skin barrier films. So some of the silicone dressings, they will say, the manufacturer will say, don't use adhesive, barrier wipes, because then the silicone can't fill into all the little dips and crevices. So really important that you read the manufacturer pamphlets, talk to your representatives, and make sure that you're using the right products and combinations so that you're not putting the person at greater risk. Okay. Just going to be talked about those things. Skin barriers, we know that they can provide a protective interface between the skin and the adhesive, as I just talked about, but just remember that they're available in many different formats, and we want to make sure that we are picking the right one for the right patient. So try to use alcohol-free products so that you're not increasing possible pain or irritation. They can be contraindicated if a skin infection is present, so we wouldn't want to use a skin barrier film if we have, say, a fungal infection to the peri-wound area. Removers, this is a question I get asked a lot, is what about the removals? So a lot of them are alcohol based, which I don't recommend normally using because they can sting and be painful. There's a lot of silicone based removers on the market. These are routine used in clinical practice. You just have to use them very, very slowly. You lift the edge, you very slowly. You need to take the time. So they can play a big role in the prevention of MARSI. You have to be slow and methodical in the removal, but they really can play a big role. The only caveat is when you use a remover, you need to make sure that you've gently removed any of the residue off the skin before you apply the next adhesive, or you will have trouble getting your next adhesive to stick. These are some of the things from our skin tear reduction program from the International Skin Tear Advisory Panel. And what we're saying is that you need to inspect the skin, investigate a previous history of skin frailty. And here's another thing I'm going to challenge you, and I'm going to ask you to be change agents on this. Right now, when we admit patients, especially to hospital or to community, we sit down as nurses and we ask them, what's your past medical history? Do you have heart disease? What medications are you on? Are you a diabetic? We ask all that history. Nobody asks the vital signs of our largest organ, which is the skin. So my challenge to you is next time you're seeing a patient for the first time and you're asking them about their past medical history, ask them about their skin history. Do you have any problems with adhesives? Have you had a pressure injury, a skin tear, or any other kind of skin injury before? Where was it? What caused it? Is your skin normally dry or moist? Ask, does your skin tear easily? Ask these questions, because if someone starts telling you, oh, every time I have an adhesive on, my skin just, I immediately break down. Or my skin tends to tear all the time. This should automatically make you start to think, oh, I need to put in a prevention program. I need to use my lowest level of skin adhesive possible. And then as well, look at their skin in general. Now, the rest of the points that are on here really are related to skin tears. But I put this up here just simply because we see such an overlap between the individuals with MARSI and individuals with skin tears. When we're looking at tension blister management, the best way to manage it is to not cause it in the first place. So lay products gently on, do not stretch them. Identify those at high risk. So those with long-term steroid use, malnutrition, or surgical procedures where edema is present. So we see a lot of tension blisters in the abdominal surgery world, for instance, where a dressing will be put on in the operating room, and then there'll be post-operative swelling, and that's where MARSI will occur. So if swelling or movement is expected, consider using tape that stretches and moves with you. But lay it on, don't stretch it when you put it on. As well, be prepared to remove the tape, maybe leave the dressing in tape, but loosen the tape and put on other tape around to prevent it from that tension from occurring. Now, other strategies is we need to get the word out. We need to start educating health professionals, individuals, and families on the importance of the proper use of adhesives in all healthcare settings. So it's not just a long-term care problem or home care or acute care. We need to educate everybody. We need to be advocates for our patients. We need to ensure that our organizations are aware of the added pain and suffering to patients and the costs of the healthcare system that's related to MARSI. We need to have organizational support for prevention strategies. We need to conduct prevalence and incidence studies to understand the true impact and causes. But one of the problems we're having is if people don't understand what MARSI is, how do you count it and monitor it? So I really challenge you, to educate your peers on what MARSI is, and then start looking at what is our true burden in our facility and how can we improve it. These should be never events. So this is showing some examples of how to apply and remove adhesive. So you can see gently applying with firm pressure, never stretching, removing slowly, not just ripping it off. You know, that old adage, rip it off like a Band-Aid. No, we don't want to just rip anything off. We want to go slow and steady. So if we're looking at medical adhesive for skin injury, there's great patient information that's out there. That article by Formarlo et al., they have this great patient sheet that you can use where they talk about what MARSI is, what causes it, who is susceptible, what are the side effects, and what we can do. So if families understand, they can be advocates for their loved ones as well. So why is MARSI such an ongoing problem? Well, we know that it's part of the problem is the attitude among care providers. We get things like, what else can I do? It's going to happen. We're using the adhesives. My favorite is, we saved your life, so you got a little skin tear. Well, but those skin tears can be so painful. They can become infected and they can prolong hospital stays. So others believe that skin damage to be as expected with adhesives. Or adhesive removal hurts, so you remove them quickly and get the pain over with. And then there's that belief of nothing else can be done. These are the kind of attitudes that we need to change because something can be done. It's so easy to prevent medical related skin injuries. We know that organizations believe that healthcare professionals just aren't using the products properly. They think that skin-friendly adhesives can be a gimmick to raise prices, and that MARSIs are not a prevalent problem. They don't think it's a problem. And part of that's our fault because we haven't been able to prove to them that there is a problem. So we need to look at the knowledge, attitude, and practices among our coworkers and come up with how can we change things? How can you implement this into practice? So my challenge once again to all of you listening is be that change agent. Figure out how can we implement this into practice and how can I change my practice? Because even if you can prevent MARSI for one person, what a great job you've done. So we need to look at educating other healthcare professionals, individuals and their families on how to select, apply, and remove medical adhesives. We need to know that all medical adhesives are not created equally, and we need to learn to pick the best adhesive for the right patient at the right time. We need to advocate to implement policies related to proper selection, application, and removal of adhesives. And we need to be conducting those regular audits so that we know what our burden is in our areas of care. So today we've given you a brief overview of MARSI, and we've left you quite a bit of time for questions and answers. So at this point, I'm going to turn this back over to, I'm going to stop sharing my screen and we will open this up to questions and answers if anybody has any questions. You can put your questions and answers into the Q&A box. Well, we're just waiting to see if there's any questions. So again, once again, I would like to thank Essity for having me come and speak with you today. And what I really want you to do is walk away with the idea that there's so much that can be done about MARSI, and we really need to look at how we can change it. So someone asked the question, is all wound maceration considered MARSI? I saw one on the slides that said it is MARSI. So that's a really great question because no, not all are actually medical adhesives related to skin injury, but we know that in some cases there can be overlook. And that's one of those really gray areas. Is it pure from the wrong dressing with wound, or is it related to the adhesive? I think one of the issues we have to remember is that when we have peri-wound maceration, number one, our patient's pain really increases. Two, it's going to delay wound healing, and it puts you at much more susceptibility to having skin injury. So we need to make, if you're having peri-wound maceration, you either have either your dressing you're using isn't absorptive enough, or you're not changing your dressing frequently enough, or you have infection or uncontrolled edema. So if you're having a lot of maceration around your wound, you need to take a step back, look at your wound and say, am I giving the wound what it needs? So am I absorbing enough moisture? Am I changing my dressing frequently enough? And I have addressed the underlying cause. So is there infection or is there uncontrolled edema? But distinguishing medical adhesive related MARSI from moisture associated skin damage can be very, very difficult, and there is a lot of overlap. Another question that we've had that has come in is, how do you treat a skin tear from MARSI? So one of the things that we do when we're looking at skin tears, particularly related to MARSI, is we look to see what kind of dressing was being used, first and foremost. And then often what we have to do is we have to pick a larger, so I like the silicone dressings. So say my wound was, I'll try and do this in American, so 2 inches by 2 inches, and then about an inch outside the wound, I had a skin tear that developed from the dressing. Then I would actually probably make my dressing, I'd pick a silicone dressing that would be 4 centimeters by, or 4 inches by 4 inches, so that I would be covering it and treating it. Or sometimes it's far enough out that you can do 2 dressings, depending. Also, at times I will use skin glue as well. So there are times that I will use the skin glues on these, but that requires an advanced medical directive. But it's really important for when you're looking at skin tears related to that are caused by MARSI is go back and look at the type of adhesive you're using and use the lowest level of adhesive, and then go back and look at how are people removing it. Okay. So the slides, the presentation has been recorded, and they will be sending this out later today, I do believe, and then you'll be able to share the recording with your staff. What is the best to treat a tension blister from adhesives? So we don't deroof the blisters. They eventually may deroof on their own, but one of the best things to do is to make sure you're not continuing to have the tension there. So once again, I go back to the non-adhesive dressings or the low adhesive like the silicones, and really, if possible, try to not have that blister covered by anything. But if you can't avoid it because it's too close to the wound, at that point, then what I will do is use the soft silicone dressings to try and prevent it. But if possible, try to have that tension blister not covered by the wound. Sometimes I'll paint it with a little bit of providine iodine just to keep it infection free. However, you know, one of the best things is just to try and not have any adhesive on it at all. So one of the questions that comes in is, I've seen a surgeon pull the patient's skin together to apply negative pressure wound therapy dressing on a larger patient to reduce the tension on the dressing, also to keep it from popping open. Would this be okay? Yes, it should be okay, as long as there's not too much tension with the drape. But often what we will see is that the negative pressure itself will hold in, so we don't have that much tension. So that should be fine, and we've used that technique, and we don't see a lot of tension blisters developing from it. Would you consider the paper tape as a low-level adhesive and recommend it over other kinds of tapes for dressings? Paper tape is one of the lower adhesive tapes, so we use paper tape a lot with fragile skin. The only thing we have to be careful of is that some individuals may develop an allergic dermatitis to the tape, so we have to be aware of that. So that's the kind of MARSI we normally see with paper tape, but I use paper tape a lot in individuals who haven't had any kind of reaction to it. Because it is a very low level of adhesive. How would you treat a skin tear from an adhesive drape removed in surgery? So if you have an adhesive drape that's removed in surgery and it's not near the wound that's going to have a dressing on it, it depends on how large the skin tear is. Normally, you can't use skin glue because of the duration and the location. So normally at that point, I will use one of the silicone dressings or a silicone sheet. So you may have guessed I'm a big silicone user, and I would spend a lot of time working with the aging population, and I find that the silicone dressings are so gentle on their skin, and that we're really decreasing our incidence of skin tear by using them. But if you don't have that available, you can use other non-adherent dressings. So you can use a non-adherent dressing, and depending on where it is on the body, you could do a non-adherent dressing and attach it with cling. You may want to depending on your care settings as well, there's the clear acrylic dressings that you can try using that you leave on for a month. It depends on the care setting, on the location on the body. One of the things that we haven't talked about that is so important is the preparation of the skin before you put a dressing on or when you're changing your dressing. So this is slightly off topic, but I would like to try and challenge you to make sure that when you're cleaning a wound, you don't just clean the wound itself, that you clean anything that's going to be covered by a dressing in the peri wound, that you're cleaning that as well. Because what we find is often nurses will clean the wound really well, but they won't clean the peri wound. And then all the bacteria from the peri wound is trapped under the dressing, and the bacteria just marches along right into the wound. So make sure you're cleaning that peri wound really well in addition. And what we're finding when patients are coming out of surgery is we use a lot of the chlorhexidine-based products or the polyhexamethylene biguanide products on their skin. And this can really cause irritation. So whenever possible, try and wash the skin off as soon as you can when the patient comes back. You can tell I work in long-term care a lot. When your patient comes back from the operating room, try and remove as much of that from the skin as you can, and then put on your dressings. Is it okay to use antibiotic ointment on a skin tear, like the one from the skin drape? So that's an interesting question, because sometimes, depending on what care setting you're in, particularly in home care, you may not have access to a silicone dressing. So using a petrolatum-based product, depending on where it is, can put a nice little moist barrier over the area that nothing will stick, and you'll get a nice little covering for it. We don't really recommend using antibiotic ointments on any wound, primarily because when we're looking at infection and infection prevention and management, the topical antibiotic ointments don't penetrate deeply to kill deeper bacteria. They just sit on the surface, and what they can do is they can actually cause sensitization, so that if you want to use certain antibiotics orally to treat infection, the wound is actually resistant to it. So we don't normally use them as well. Frequently, they get ordered in cream form. And then what happens is that you will end up with a reaction to the base product. So the reason that the antibiotics ointments we believe actually work at all for wound healing is actually the petrolatum base, so adding that moist base to them. So I hope I've answered that question for you. I'm just going to check over in the chat and see if there's any questions over there. I'm not seeing any. So I'll give you a few more minutes to see if any more questions come in. But I guess, for me, some of the biggest things we really need to look at is just making sure that we're preparing our wound bed purposefully. So as I said, making sure that you're cleansing the peri-wound skin really well, you're cleaning the wound itself, and that you pick the best adhesive for your patient at that time. And sometimes, especially if we have chest tubes or different types of tubes that we may use, unfortunately, sometimes we have to use stronger adhesives, right? IV, PICC line, art lines, when we need to secure them, depending on where you live and work, not everybody has access to the silicone film dressings. So sometimes we have no choice but to use film dressings, and we know that they're going to be a problem. But just knowing that you've put a strong adhesive on your patient and that when you remove it, you're going to have to be super careful on removal. That alone can prevent MARSI. So remember that there are going to be times when you can't pick a low level adhesive, right? You can't use paper tape to secure a chest tube. Just not going to work very well. So you need to be cognizant, okay, I've used a high level of adhesive. I got to be very careful when I'm removing it. Okay, so I'm not seeing any other questions coming in. So I would like to thank you all for joining us today. I want to thank Essity again for sponsoring this session. And I'm going to hand this back over to our Essity team now. Thank you so much.
Thank you so much, Kimberly, for this informative webinar. And everyone else, before we close today, I do want to provide some additional information. If you would like to receive CE credit for this webinar, you must complete the course evaluation within 48 hours. I have posted it in the link in the Zoom chat box. This link will also be shared in a follow-up email that will be sent tomorrow. So we'll send the recording and this PowerPoint presentation in that email tomorrow. So thank you again, everyone, for your time, and I hope you all have a great day.